Hi, Masarawa.
Hello, good evening.
Good evening. How are you?
Very good. Surviving.
Okay, okay, good.
For you
It's
guys,
Eid Mubarak. Huh?
good feedback.
Hello, hello,
Me and you.
hello. Can you hear me? Can you get me what?
Here we go.
Can you get me what? Hi, everyone. Hi, Dima.
Hi, how are you?
Good, good. Eid Mubarak. How are you?
Thank you. We are good, thank you.
Okay.
أنا عاطفك بخير.
وانت بألف خير يا رب من الجميع إن شاء الله.
Okay. I think we should give like a few minutes for the others to join, so we can start. We give like 5 to 10 minutes to see if the others can join us, so we start together.
Okay, no problem.
Okay. Hi guys, it seems like the others are still not joining yet, so we might just start off without them for now. We might just have to start off without them for now.
Okay.
Yeah.
I don't know
So
about
can we?
Dima, if she can contact any of the guys if they have a group or something together.
Yeah, I think they should have a WhatsApp group chat. Yeah, she might be able to send a message, a reminder to them. Maybe.
I guess I'm the only one from Palestine. Most of them, I guess, from Egypt. I don't know anyone actually.
Okay.
Okay, okay. So we'll probably just start off. Maybe they might join sooner. So week 4, we'll be looking on the respiratory, cardiovascular, and neurological system. So we'll be looking at nursing interventions, right? Critical assessment and nursing interventions in these various systems. I think the material was made available, was it 4 days ago? I'm trying to find out if you guys actually had access to it before today.
Just a brief from my side, just a brief look, to be
Just a
honest.
brief. No problem. We'll just have a run through, like a quick run through it, because it's really cumbersome. We really cannot talk about everything like in 1 hour, 30 minutes, in 60 minutes, 90 minutes. Sorry. So let's start with the respiratory system. Yeah. So with the general assessments of the respiratory system and management of
I'm sorry,
conditions.
can you make just the screen bigger?
The screen bigger?
Yeah.
I think this is it. How about now? How about now?
Yeah, a little bit better.
Okay. So, like I was saying, with the respiratory system assessment and management, we're looking at general respiratory assessments, right? And the key actions probably include like the key nursing actions, right? They include the monitoring for breathing pattern, breathing rate, breathing pattern. You have shallow breathing, deep breathing, level breathing. You have to observe for cyanosis and or use of accessory muscles in breathing. Okay, and you also have to check for chest symmetry as well. In addition, you have to listen to like adventitious long sounds like crackles and wheezings. Those are all respiratory assessments we need to pay attention to when looking at the respiratory system. Okay, and in identifying the acute respiratory problems, you have some key signs and symptoms associated with it. Okay, so identifying early and late signs of respiratory distress. I mean, it's very, very important because in maintaining and sustaining well-being. Remember, we're talking about ABCs here, and airways, they are all associated with respiration. Okay, so we have some key critical clinical conditions like pneumonia, asthma, hypoxemia, and others that we'll take a look at. We'll take a look at in the course of this discussion. So we'll look at the manifestations, priority actions, and some rationales associated with them as well. So let's take a look at pneumonia. Let's start with pneumonia. So with pneumonia, during assessment, you probably will notice rapid, shallow breathing and confusion. So in pneumonia, we will notice, like I was saying, we'll notice rapid, shallow breathing and confusion. So these are all signs of significant like gaseous exchange problem, okay, which is associated with the hypoxia, and will likely, so all these, they will likely lead to respiratory failure. So the clinical assessments will have like a respiratory rate of 30 and above, right, with confusions. Why? Because since it's associated with hypoxia and there's diminished oxygen supply, okay, to the brain, this will probably lead to confusion. The brain is very sensitive to oxygen deprivation. That's why most of our respiratory problems, you find them associated with either decreased level of consciousness or confusion. Okay.
That's the first sign.
Next, yes. So next we're looking at like hypoxemia itself. So this is, I mean, this is like low levels of oxygen in blood. Okay, I think that's like the main difference between hypoxemia and hypoxia, because hypoxia, it's like diminished oxygen supply to organs. Guys, can you hear me clearly?
Yes, we're with you. We're with you.
Okay, because I think my video was a little bit rusty. So, as we know, hypoxia is diminished oxygen supply to organs and tissues, while like hypoxemia is like low levels of oxygen in blood, which we can assess or find out from, like we can find out or know by looking at the arterial blood gas values, right? So clinical findings associated with the hypoxemia, they would obviously include like the restlessness and confusion. And same reason is like with the confusion, like I said earlier, the brain is very sensitive to oxygen deprivation. So most likely evidence presentations or first presentations will probably have its this confusion. Another
So
we have
irritability.
is yes, irritability as well, mostly in children. You notice that in children too. So our next condition shall be asthma. And in the acute exacerbation, we have wheezing. This is where with assessment, you're listening to adventitious lung sounds, right? Because there's narrowing of the airways during asthma exacerbation. So you have wheezing, diminishing breath sounds, confusion, severe airway obstructions, and bronchial spasms. Okay, and during this, so bronchodilators like albuterol inhalers is given to relieve acute bronchial spasms, right?
First line.
Okay.
Albuterol.
So our next stop is pneumothorax. With pneumothorax, air enters the pleural space, that is the space between the lungs and the chest wall, right? So normally it has negative pressure. So when air gets into it, you have positive pressure there, and the lung cannot expand properly, right? Because the pressure now is pushing against the lungs. The pressure from the pleural space is pushing against the lungs, so the lungs cannot expand properly. Okay, so let me just try to illustrate something here. Is my video stable enough?
Yes, yes. From
Yeah,
here.
yeah.
So like, okay, so like I'm trying to illustrate here, you have, let's say this is our chest wall, right? The pencil, the first pencil is our chest wall, the other one, this is the lungs, and the space in between, this is the pleural space, right? So during inhalation, like the lung expands, it goes, contracts like that. So if, let's say this is air in between the pleural space, right? So the lungs, they cannot expand correctly, expand or contract, okay? So it will lead to lung collapse. I don't know if I'm trying to explain it, that you guys are getting it.
Yes, yes. Got you.
Okay.
The more air in the between the lungs and the chest wall, the more chance of lung collapse.
Yeah, when the air gets there, the lung actually collapse. So because the lung, it cannot expand or function properly, so it probably you collapse.
Unless we decompress, which is the emergency.
Yes, which is an emergency. So upon assessment, you have absent lung sounds, because normally the lungs, like you have collapsed lungs, so you won't have the lung sounds on the affected side. So you have absent lung sounds, right? You have sudden dyspnea. This, it requires like immediate interventions. Like I said, it's an emergency. Okay. And the immediate interventions that is usually carried out, you have instilling of chest wall of chest tube. You have to instill a chest tube. Okay. So like I was explaining with this, let me just go back to this, our two pencils here. Like this is the chest wall, this is the lungs, and this is the pleural space. So the lungs, they cannot contract or relax properly. Now you instill, once you instill a chest tube, the purpose of the chest tube now is to establish a negative pressure back within the pleural space. And how does that happen? It will happen like the chest tube acts as a one-way valve to remove air, like the air in the pleural space, right? So once the chest tube is instilled into the pleural space, during inhalation, right, or breathing, like when you inhale, like your lung expands, a push against the air, it comes out. It comes out through the chest tube, right? Like that's probably how it functions. So the chest tube is normally connected to a water sea chamber. So you once the air is being pushed out, you find it like the evidence of it being pushed out and working is that you see the water sea chamber bubbling. Okay, like you get it bubbling once the air is going out, it goes in the water sea chamber, it bubbles, and just like that, intermittent bubbling. Okay. So, but once you're taking care of a patient like that with a chest tube, and if you notice, you have to actually watch the water sea chamber too, because if you notice continuous bubbling, it shows that there's probably a leak in the system, because like I say, it's a one-way valve. So if it's a leak, if there's a leak, air is going back into the pleural space, so it's not actually serving its purpose. Okay.
Yes.
So you also check for any blockage, obstructions in the chest tube, like which can prevent air or fluid from escaping. So are we following?
Yes.
Okay, good. The next we'll have is tuberculosis. So with TB, the classical findings we will know it's you have night sweats, right? Hemoptysis, right? So these findings, they are all indicative of TB, tuberculosis, and once you have these findings, like you need to like escalate, and then infection prevention measures are supposed to be put in place already. Airborne precautions. Okay.
Yes, we are with you.
Okay. So the next we have is COPD, as chronic obstructive pulmonary disease, and in this the goal is to maintain oxygen saturation, right? To keep the oxygen saturation at 88 to 92%. So in the situation of exacerbation, we encourage pulse lip breathing, right? So this breathing it maintains oxygenation by prolonging the exhalation phase of respiration. Like this prevents trapping of air in the lungs, right?
Right.
So like our priority intervention or management here, our keynote is like to keep the O2 saturation, 88 to 92. Try as much as you can to keep it that way. The next we'll have is we have to look at respiratory management of post-op and post-procedural patients. Like after this, when we have done this assessment, and probably their interventions have been carried out, we have to take care of the patient. If there's like an operative case or just a procedural case like a bronchoscopy, we need to like take care of it, take care of the patient afterwards. So let's look at some of the interventions that we have to check for early healing. Yeah, we have like post bronchoscopy care. So in a bronchoscopy, since the gag reflex is suppressed during the procedure by anesthesia, okay, we have to check. We have to check for it before administering food or water to avoid aspiration. Like you need to you use the tongue depressor, and then you touch the tonsillar area to assess for gag reflex. If the patient can gag, shows that if something gets into the airways or out, the patient can actually gag it out. So this measure, it prevents aspiration of either water or particles to the lungs. Now look at the atelectasis, which is just like prevention of lung collapse. So this is done by helping expand the alveoli, and we keep the lung clear. Keeping the lungs clear is very, very essential for recovery, and you encourage early ambulation. Use of incentive spirometers is very, very effective, since the lung, like it's a case of lung collapse and the lung actually shrinks. So you need to use the incentive spirometer, like reinforce the teaching of how to use the incentive spirometer. The patient places the, the pad on the mouth closely, firmly, and you inhale to the mark. Okay, so all this is just to like promote or help promote lung, like the lungs expansion or activities. The next we look at is like chest tube management. Like I mentioned earlier, with the chest tube management, you have to monitor, check for occlusions in the tube, or things or blockage, anything that can block air or water from going up. Then you check the water sea chamber for what bubbling. Okay.
Mhm.
So I think that is it for respiratory. We look at the cardiovascular system. So looking at the cardiovascular system, it's the pump system of the body. In the cardiovascular, it's very, very essential, because pump intervention is necessary to restore normal function or reduce the extent of damage that has already occurred. So once assessment is done and we notice any irregularities, prompt intervention is very, very necessary. So our intervention, most of our intervention, or some of it, will be like, the main reasons for it will be like to reduce the workload of the heart, reduce cardiac output, right? So like, let's look at critical findings to report immediately and their manifestations. So some of the critical findings, you have myocardial infarctions, hypertensive crisis, you have cardiogenic shock. These are all very critical conditions that they require immediate interventions. So with the myocardial infarction, can we get a difference between the myocardial infarction and angina pectoris?
About the myocardial infarction and the angina. The
Yes,
angina,
yes.
it's like ischemia. Ischemia could be stable or unstable. Myocardial infarction, already the cardiac muscle is start to dying.
Right. And some like the classical or clinical manifestations associated with it, like presentation, the patient's presentation, you often hear things like crushing chest pain, like radiating to the left arm or the jaw, right?
Yes, central.
And this is not relieved by nitroglycerin. With angina pectoris, it's relieved by giving nitroglycerin. Like you said, it's
Resting
yes,
GTM.
yes. So once we have noticed these findings already, once a patient comes in complaining about this, and we assess and we notice these are all manifestations of myocardial infarctions, what do? You need to escalate immediately, report immediately, because it's an emergency situation that requires prompt intervention. So another emergency situation that requires prompt intervention, you're looking at the hypertensive crisis. So with hypertensive crisis, you have BPs above 180 and 120, and symptoms. You have symptoms like headache. You have severe headaches and blurry visions. These are all like classical signs or manifestations of hypertensive crisis. So it's a medical emergency as well. So you escalate once you get these findings. So another will have cardiogenic shock. So in a situation where, like you said, the hand muscle, it's in a situation like myocardial infarction, like prolonged pace or heart failure, the heart is unable to pump blood. You know, the heart's main function is to pump. It's like the body's pump. So if the heart is unable to pump blood, there's decreased oxygen, there's decreased blood volume or blood supply to organs or other parts of the body. Okay. So when there's decreased blood volume or blood supply, you often have signs and symptoms of shock. And I think if we can recall the signs of shock, like signs and symptoms of shock, you have like low BP, right? Cool, clammy skin, right? These are all classical signs and symptoms of shock. So once the heart is unable to pump, you have this problem like a cardiogenic shock. So with all these problems involved, you might have take a look at the interventions like we have done here and some medications like cardiac medications. I think in our previous class in pharmacology, we talked about some medications. We made mention of digoxin, which is a cardiac glycoside, and it's often given in patients with heart failure, right? And Dima, I don't know if you can help us. You can help us with the patient assessments before administration of digoxin, like we said last class.
Yeah, we have to check the heart rate for a minute, and we have to notify the provider if the heart rate is less than 60 beats per minute.
Exactly. Excellent. So you need to assess the patient first. You count the apical pulse for a minute, and if it's less than 60 beats per minute, you notify the provider. You hold and notify the provider. And next, you have to watch for toxicity. Like we said the last class, this is a high risk medication, so you need to watch for toxicity. And what were the signs and what were some signs and symptoms of digoxin toxicity, like we discussed during the last class?
Can you repeat it, please?
I mean, like there's some yes, some of the signs and symptoms associated with the digoxin toxicity.
Maybe yellow green
Like we
vision.
discussed last class.
Yellow.
Correct. I think your network is probably having a problem, but it's okay. I can probably understand you. And you're right. Like we said last class, you have halos around light, like yellow-green visions. The patient report the yellow-green visions. Those are halos around light. That's a clear indication of digoxin toxicity. Okay.
Yeah, right.
Yes. So another medication we'll look at, another group of medications are like diuretics. So with diuretics, before administration, you know there are are two types of diuretics. We have potassium wasting, right, and potassium sparing diuretics. Exactly.
The loop diuretic and the potassium sparing.
Yes. So before administering the potassium wasting diuretics, like furosemide, thiazides, what do? You need to assess the level of potassium, serum potassium, right, to prevent hypokalemia, right?
Hypokalemia.
Hypokalemia.
Yes, to prevent hypokalemia and hypotension, and
Potential.
as well as good, exactly. So as well as potassium sparing diuretics before administration, we need to check, right? Check the potassium level to prevent hypokalemia. Since it's a potassium sparing, so we need to check the potassium level to watch for hypokalemia. And looking at hypokalemia, can you help, Robert? Can you help me with like a clear indication of hypokalemia as seen on the ECG?
We have big T waves, I think, in hyperkalemia.
Yes,
Big,
yes.
a tall
Like in
peak wave on
hypokalemia,
hyperkalemia and almost flat T
yes.
wave widening on the hypokalemia.
Right. Yeah, so that's probably true. That's excellent. You have peaked T waves and you have widened QRS complexes in hyperkalemia. Okay. And in the case of hyperkalemia, how can we correct it? Who has an idea?
You mean hyperkalemia?
Yeah, hyperkalemia.
Hyperkalemia, we can use the insulin also.
Calcium gluconate.
T5. Calcium gluconate.
Okay. Exactly. We can use calcium gluconate, we can use insulin, and we can use as well K-exhalate.
Oh, okay.
Those are all correct. Yeah, you can
About
use those are all. Yeah, those are all correct. And with hypokalemia, how do we correct?
the
We just give potassium.
potassium
Slowly.
KCl
Okay,
infusion.
we give potassium, and we never give potassium IV what? IV push, fast
No,
push, right?
Never push.
Right?
Slow infusion.
slow infusion.
Yes. So infusions, potassium is never given as a fast IV push. So another class of medications we're looking at the anticoagulants, and we looked at it last class as well. So with anticoagulants, this you see follow the same safety precautions like we said the last class. You check for signs of bleeding, bruises around the mouth, right? And you check. Let's see, you check for signs of GI bleedings too, like what?
Black tar stool.
Exactly, black tarries too, and
Uh, uh,
black ground
um,
emesis.
black emesis.
Yes, exactly. So we do all those assessments before administering anticoagulants as well. And in administering anticoagulants, the lab values, like we said last class, you check for if heparin or warfarin, you check as well. You check the INR, check the APTT. Yes, and the antidotes as well. They should be present. Okay.
Okay.
So
Vitamin.
our next class of medications we'll have it's nitroglycerin. So nitroglycerin, it's a vasodilator. So it can significantly cause hypotension. Okay. So when administering nitroglycerin, you need to ask the patient to either sit or lie down, right? In case of hypotension, the patient is prone to falls. So you ask the patient to sit or lie down and you instill fall prevention procedures. As well, before administering, like we said last class, before administering any medication like a blood pressure medication, what do? You assess the patient and what do you check? You check the blood pressure.
Pressure.
So in the case of administering the, yes, in the case of administering the vasodilator like nitroglycerin, we check the blood pressure as well. And if the BP is like, if it's 84 on 50 or below, right?
We
It's
don't
an
give.
indicative that you have to hold. Yeah, you don't give, you hold the medication. Another class of medication we're looking at, it's beta blockers, and these are all the LOLs, the LOLs, right? Propranolol, all those. So in administering that, what you check for the BP, like we just said. Always assess, check for BP before administration.
Heart rate and
So
the
far,
blood
do we have
glucose.
good? So far, do you have a question as we're going forward?
All good from my side.
Okay.
No problem.
What about you, Dima?
Yeah, go ahead.
Okay. So our next step, we're looking at heart failure. Looking at heart failure, and like we said, the heart is the main pump of the body. So if the heart is failing, it means the pump is failing, and you cannot have blood supply to the body. Blood cannot go in or out. Like the heart, the body is like a valve system, a closed valve system, right? So a problem in one section of the valve can potentially affect all other parts. So if the pump is having a problem, you either have a backup of fluids or inadequate blood supply or oxygen supply to tissues. And in heart failures, we have two types, like the left-sided heart failure and the right-sided heart failure. We can all recall, right? With the left-sided, we know the left ventricle cannot pump oxygenated blood, right, to the body. So if the left ventricle cannot pump oxygenated blood to the body, it backed up back in the lungs. And when oxygenated blood is backed up in the lungs, during assessment, what do you find? You hear sounds like crackers in the lungs. Okay, and the patient too. Yeah, you have upon assessment, you have crackers in the lungs, you have shortness of breath when lying down, because when lying down now, it reduces surface area for expansion, lung expansion, which the lung is already being backed up with fluid already. So you have difficulty breathing or shortness of breath when lying down. Then with the right-sided heart failure, when the right ventricle is weak, causing backup of blood in the system. So you have systemic congestion, right? As seen
Right.
by edema, like rapid weight gain. Yeah, you have rapid weight gain. You have edema. So in that, you have medications for correcting that. You often prescribe diuretics, which will be aimed at reducing vascular congestion, and this reduces the workload of the heart that's needed to pump, right?
Yes. That's my.
And in patient, yes, and in patient education, what do? You limit, you reinforce teaching or you assess for patient understanding first. Yes. You educate the patient on the, excuse me, like reinforce teaching about the importance of limiting sodium intake. We all know where sodium goes, water follows. So if the patient continues the normal sodium intake, what happens? Is fluid retention, right? Increasing the cardiac workload. Yes. So you require the patient to limit the sodium intake like to 2 grams daily, right? And as well, you reinforce teaching on the importance of weight gain to easily assess or pick up and identify worsening conditions. Like you educate the patients of importance of weight, like getting your weight every day, consistently getting the weight every day, and yes, the importance of getting the weight every day. And another way to assess the patient's understanding, like the patient has to repeat what you just said in his or own words. Like you can with patient teaching, you can you instruct the patient like you have to get your weight every day at this time with the same or similar clothes, right? So the patient has to like repeat that to you to prove that he or she has understood. Like I'll have to get my weight every day, almost at the same time with almost the same dressing, right?
Yes.
So since we have looked at the pump issue, let's take a look at let me see. Let's take a look at the vessels, count and distribution. Are we having any problems so far?
No, I'm good. Dima?
Okay.
That's okay.
Okay. So looking at after we have discussed the pump, we cannot discuss the pump without talking about how the means of which, like the routes, the blood actually travels to other parts of the body, the problems they might face. So we're looking at the vessels issues, and predominantly we will have, like it's in here, PAD, peripheral artery disease. You have DVT, right? You have VTE, and then you have varicose veins. But these are like very critical and they are very, very critical and tough conditions that if they are not addressed immediately, they can cause serious problems. You have like the peripheral artery disease. With the peripheral artery disease, this is like you often get complaints like the patient complains of leg pain when walking,
Warm.
right?
Warm
Because
cough.
yes, leg pain when walking because it causes occlusion either by atherosclerosis, right? Causes occlusion of the arteries on the periphery, like the lower extremities. So either blood cannot go through or come back, right? So yes, poor oxygen supply to the area. During exertion or walking, the patient experience a lot of pain, and this is known as intermittent claudication. Okay.
Okay.
Yes.
And the next you have is DVT, deep vein thrombosis. So with deep vein thrombosis, you have classical manifestations like the pain, redness, and swelling in one leg. Okay.
Warm.
And with warm as well. And with deep vein thrombosis, we should note that we are not supposed to. We should never massage it.
Yeah.
Why?
Yes. So we don't move any clot.
And
Yes, like you said, if we massage, we run the risk of dislodging the clot. And if it dislodge the clot now, it can travel back to the lungs,
Yeah,
causing PE.
yeah.
Yes, causing PE,
Embolism.
which is very, very fatal. Yes. So next we have this VTE and I mean preventions, like key prevention, preventive methods. You have to apply like sequential compression devices and encourage early ambulation, like compression stockings, right? Compression socks. Encourage encourage that, and early ambulation to improve circulation. Okay.
Mhm.
So I think that is that for cardio. Let's take a look at the neuro. Do you have a question on cardio?
No.
Nope.
Okay. So with neurological assessments, you know, I mean, neurological assessments and interventions, you know, they are very, very important because a slight change can have a very devastating effect on the entire body. Right? We're talking about organ vitalities. The brain is like one of the most important like vital organs in the body. So a slight change or problem they can probably affect either parts or all of the body permanently. So we need to be able to spot life-threatening conditions like CVAs, ICPs, spinal cord injuries, right, and other neurodegenerative conditions or disorders. Okay. So let's take a look at the ICPs and the CVAs, like intracranial pressure. So with the intracranial pressure, it becomes a problem when the pressure exceeds 15 to 16 millimeters of mercury. And with this, you often experience early signs like a severe headache, vomiting, decreased level of consciousness, and pupillary changes. Right? And with late signs, you will see a Cushing triad. Do we know the Cushing triad?
Yeah, it's just
The Cushing triad is like you have
Cardia and
bradycardia, hypertension, and
irregular respiration.
bradycardia. Excellent. You have bradycardia, hypertension, irregular respiration. Those are all late signs you see involving increased ICP. Do we know the difference between Cushing triad and there's another word that's always confusing people. You have the Cushing triad and the Cushing's syndrome. They are all Cushing, they are two different things, right?
the late signs.
You know, with the Cushing syndromes, it's sorry.
I didn't get your question. I didn't get what you said.
No, I was just saying like because we have two uh, we have Cushing triads and we also have Cushing syndrome. So people are often confused between Cushing triads and Cushing syndromes, right?
Oh, okay.
They're like completely two different things. Yes, like completely two different things. Like with Cushing syndromes, this is like just oversecretion of the adrenal cortex, leading to high
Okay.
cortisol. So it doesn't have anything. Yes, that's like the Cushing syndrome.
Cushing
So
syndrome. Uh, about cortisol level, hormonal disorder.
Yes, yes. That is the Cushing syndrome.
Yeah.
Exactly. So after assessment, like these are the findings you find like on adults. You can also find this in pediatric clients, but in the pediatric you also observe bulging, fontana, and
Yeah.
irritability. Okay, and for traumatic brain injury, right, or basilar, traumatic brain injuries like skull fractures or basilar skull fracture, you often see manifestations like raccoon eyes. You know raccoon eyes, right?
Yes,
Yes, you see like raccoon eyes, and you have this
behind the ear.
sorry to forget battle signs.
Battles.
Yeah, battle signs behind the ear and the raccoon eyes. These are all indications of traumatic brain injury or basilar skull, like basilar skull fractures. As well, you have leakage of cerebrospinal fluid, like clear fluid from nostrils or the
Or the
ears.
ear.
Yes, the ear, nostrils, yeah, nostrils or the ears. So in this case, you position the client's head of the bed at 30 to 45 degrees, right? So this position, it facilitates drainage, venous drainage from the cranium through the jugular
Jugular
veins.
vein. The jugular vein.
Yes, so one, yes, through the jugular veins, and that reduces, it helps to reduce the ICP.
Mhm.
Okay. So we look at stroke. Let's look at stroke CVA. So with CVA, you have to always remember this, the acronym FAST, right?
Yes.
Yeah.
Once
Pressure drop.
we see these manifestations pertaining to FAST, yes, exactly. We have the FAST, like the facial drooping, arms weakness, speech difficulties, right? And then time. So it's like an emergency situation where you don't wait to observe. Once you have seen this pattern already, you escalate, notify the provider, right, and ensure the client is NPO, right?
Right.
So your job there as a nurse, once you've done your assessments, your findings, and these are all the indications, you notify the provider, right? You ensure the client is NPO to prevent aspiration, like you don't administer anything orally to prevent aspiration, and that's that. Then we look at seizure. Another neurological complication we have is like seizure. So with seizure management, I mean, this is like you have to manage sudden abnormal electrical activities in the brain. It's essential in preventing secondary injuries. You know the 4 types of seizures, right?
Yeah. Tonic-clonic and
Yeah.
status epilepticus. And autonomic dysreflexia, I think, and no.
Also the absent seizure.
Autonomic dysreflexia. Yes. You
Tonic.
have absent seizure, myoclonic seizure, tonic-clonic seizures, right? Atonic seizures. So, and this will be like we'll be looking at management of the most predominant, that is the tonic-clonic seizure. So here the priority action will be to maintain a pattern airway, right? So we don't introduce anything. You don't introduce anything in the patient's mouth. You maintain NPO. You don't restrain the patient, right? Then you lay the patients on the side, right?
To prevent aspiration if there is
In
any.
case there's any secretion, yes. In case there's any secretion, it can come out of the mouth. Like all all this is to prevent aspiration. Okay.
Yes.
So once all this is done, you also note the time and the duration, the time it started and how long the seizure took. So we know that will be able to tell us the difference between like seizures and status epilepticus.
Status epileptic.
Yes. So we know with status epilepticus, that's like seizures lasting longer than 5 minutes, and this can lead to cerebral hypoxia. So maintaining pattern airways, it's very, very essential. We notice there's a pattern to this. Airways, like it's very, very important in this. So you always try to maintain a pattern airway. So we'll take a look at our next stop. We'll be looking at the neurodegenerative and the neuromuscular disorders. So with we'll be looking at assessments, findings, and management of disorders like Parkinson's, Parkinson's disease, MG, like myasthenia gravis, and GBS, right? We know Parkinson's, it's a neurodegenerative disorder, right? I mean, that is caused by damage of the dopaminergic neurons in the brain. And its classic signs or manifestations, you often see resting, tremors, shuffling gait, okay?
Mask face.
Resting tremors, yes. Muscle rigidity as well.
Right.
So, as a nurse, what could be your during plan of care for patient with Parkinson's disease? What are your key considerations?
About swallowing aspiration, that's the one of the main things
Good.
to prevent aspiration because of the dysphagia and the
Excellent.
fall risk.
That's good. Yes, that is it as well. So you have to prevent aspirations and instill fall prevention. With aspirations, we know with aspirations we are supposed to like encourage. We encourage I mean small
Small
frequent
meals.
meals with soft food.
Soft.
Yes, with soft food. That's pretty easy to swallow to prevent aspiration. Since the patient is like more prone to like a dysphagia. Okay.
Okay.
The next we're looking at is myasthenia gravis. Can someone help us with pathophysiology of myasthenia gravis?
There's a muscle weakness and
Generalized.
there's drooping eyelid with the difficult swallowing and also respiratory distresses.
That's absolutely correct. Very right. So these are all correct because with myasthenia gravis, it's an autoimmune disorder that is caused by destruction of acetylcholine receptors at the post-synaptic region of the like neuromuscular junction. So when there's disruption in the neurotransmission, right, in that junction from the neuron to the muscular junction, you probably have muscle weakness since they cannot receive the impulses, right? Like you said, you have the facial drooping, you have the muscle weakness, okay, difficulty breathing as well because it will affect the intercostal muscles, right?
Yes. Respiratory distress.
Yeah, these are all respiratory distress. So, like we are just saying, upon assessment, you find all these things like general muscle weakness, drooping eyelids, dysphagia, respiratory distress. So you maintain airway as well. So the next step, you have the Guillain-Barré syndrome, GBS. Can someone help us with the pathophysiology as well?
It's like the weakness of the muscles and the nerve ending, starting from it's ascending actually, starting from down, the legs going up, which affects the main concern, the diaphragm, the intercostal muscles. Respiratory
probably
failure.
good.
That's what we're concerned about.
Yes, you're very right. This GBS as well is an autoimmune. It's an autoimmune disorder. It's caused by the destruction of the myelin sheath. Myelin sheath of nerves from the peripheral nervous system. That's why you see it's often called ascending paralysis. So it starts from the lower extremities coming up, right?
Yes.
So, yeah. So since it affects the peripheral nervous systems, and I mean, you like I said earlier, you see the ascending paralysis. You have the muscle weakness, like you mentioned, right? Then, as you made mention as well, so you monitor for respiratory compromise. Since ascending paralysis, it will affect the diaphragm and intercostal muscles, leading to respiratory failure. Okay.
Okay.
So there's another autoimmune disorder too that affects the myelin sheath. Can someone take a guess? You have this GBS and multiple sclerosis. You know about multiple
The
sclerosis?
MS.
Yes, the GBS and MS. Good. So these are all neurodegenerative disorders, or autoimmune. Sorry, these are all autoimmune disorders affecting the nerve, like destruction of the myelin sheath. What could be the difference between the GBS and MS?
Multiple sclerosis, I think it's a chronic autoimmune disease.
Okay, I think
The pathology.
the most
The
important or the
pathology.
significant difference here is the pathology, because they all affect the myelin sheath of the neuron, but now it's the position. Remember, with GBS, it's the PNS, right? But with MS, it's the CNS, central nervous system, like the brain and the spinal cord. With multiple sclerosis, it's the same as Guillain-Barré syndrome, but where the nerves that are being affected are the nerves of the central nervous system, right?
Mhm.
Okay. I think we've had a run through on the most significant, but do we have like a question or some few questions pertaining to what we have just been discussing so far? Is there like a question? Is everything okay?
Yeah.
Okay. So let's just take a look at some few questions to let's test our knowledge on what we just discussed so far. So let's
So
look at this short quiz. No, go on, Dima.
I'm sorry, I was just want to ask if the class time will be fixed on today's time, 1 hour before than usual.
Yeah. 1 hour before the, which I think since like that's a good point to note as well, because since the attendance today was not really that good, maybe we can look for a convenient like time. Maybe we'll push it 1 hour 1 hour after, 1 hour ahead.
For
I
me,
don't know.
uh,
For me also, it's
Sorry.
okay. I don't know about the others. We got few others joined.
The thing there is after this as well, I have a class with the next group, so that's another conflicting idea. But if this time is convenient for everyone, I think we can stick to it so far.
I don't know. We can ask Muhammad and Nibras. Actually, they joined us. I don't know if they have any connection with others. Muhammad?
Okay.
Yes.
I don't know about the timing. We discussing about the timing. If it's good
It's
for you,
acceptable for me.
because we started actually like an hour ago.
Okay.
Yeah, because of duty. My duty is a 12 hour.
Yeah.
Finish
Oh
at
my God.
7.
Bless your heart.
So difficult sometime because too much patient coming.
All right.
So
I don't know if
So
you
if
have
you
any
can
connection
send
with
the
other
right?
guys
email,
in the group.
can you send email as remember the alarm? We will start the class so everyone will be ready.
Okay. Okay. Sure.
Because usually I know you
So
start like
we always
7,
have that as well.
7:30.
Yes.
Just if you can send like message or email like alarm, we will start after 1 hour, we will start after 30 minutes. So we can be ready.
Okay. Okay. I think there is a with the Google Classroom and Google Meet. There's always a reminder, but as well, I'll also add to it. So I'll keep reminding before the class,
That's
like
how I
30
got
minutes
it.
before the class, 1 hour before the class. I'll send. Yeah.
Not always
The
we
Google,
receive.
yeah, the
Not
Google
always
Meet.
we receive message that the class will be
Okay.
started. Yeah, just I know today and last week, just we will start like 7:30. That's why I joined to the class.
Okay. Okay. No problem. I'll be sending like there's an automated reminder with the Google Meet that I'll be sending the reminder to as well.
We will be grateful.
Okay. So we have all agreed on the time, like the same time next week.
Yes, 7:30
okay.
UAE time.
Okay.
7:30 in Middle East or
Okay.
UAE time? Oh,
Yeah, time, like
UAE time like 6:30 p.m. in
six.
Saudi Arabia.
Yes, exactly.
Okay, deep.
I believe 5:30 for the Egyptian guys in Egypt.
No problem. I am ready.
okay.
Yeah, in Palestine, 5:30.
Good.
5:30 Palestine. We hope you guys stay safe there.
That's excellent.
Can you just every week download in the YouTube so we can refer back, or we can see it one more the time?
Okay. I think I'll ask the team as well. They'll send the links to the video so you can also watch it on YouTube.
Yeah, that's why we can see it again and again.
If you join, if you join today, yes, you can always see. So let's take a look at these few questions just to test our knowledge on what we discussed today. So with question 1, it states, what is the most critical nursing assessment to perform after a client has undergone a bronchoscopy, and what is the rationale for this action?
Gag reflux.
Okay, assess with the gag reflex, right?
Right.
What is the rationale? Now to prevent aspiration.
Respiration, yeah.
Good. So the next question states, explain the purpose of crossed lip breathing for a client with COPD and how it improves their oxygenation.
Preventing the lung collapse with expansion of the lungs and the air exchange.
Go on.
Prevents maybe air trapping and improve gas exchange.
Good. Like you said, right? Prevents trapping of air in the alveoli, right? And improves
Yeah.
gaseous exchange, which improves oxygenation. So question 3 said, describe the classic assessment findings that would suggest a client has developed pneumothorax.
Dyspnea.
Diminished lung sound,
Correct.
difficulty breathing,
Sudden onset.
Like we said earlier, sudden
onset of dyspnea, and if you clinically you find absent breath sound on the affected side of the chest.
Exactly. Those are all like the classic assessment findings that would suggest pneumothorax. Since it's associated lung collapse, you have absent lung sounds on the affected sites, right?
Mhm.
Right.
Question 4, you have a client with heart failure is prescribed diuretics. Explain the primary therapeutic goal of this medication in managing heart failure.
To decrease the preload of the heart. If you decrease the body intravascular fluid volume, so you
Volume. Yeah. Go on, like say you're very correct. If you decrease the fluid volume,
Yeah,
you decrease the preload and you decrease the workload of.
yeah, I mean by decreasing
All these go on, please.
okay. if you, this will reduce the cardiac workload and to maybe relieve symptoms of the congestion of fluids in the body.
That's correct. So when diuretics have been administered, it helps in the like you lose fluids, and when you lose fluids, what happens? It decreases the fluid volume, right? Intravascular fluid volume, and if intravascular fluid volume is decreased, since fluid is if fluids are backed up on the extremities, you have reduced swellings. If fluids are backed up on the lungs because the heart cannot pump, yes. So it relieves the signs and symptoms of like pulmonary edema as well. So question 5. So what key safety instruction must a nurse provide to a client who is prescribed sublingual nitroglycerin for chest pain?
To sit down or lie down before taking the medication, as we said.
And check blood pressure.
Good. And in patient education, you need to assess if the patient is taking any other nitric containing medications like sildenafil, Viagra, right? To prevent dangerous hypertension as well. Is there a problem?
Yes. Oh, good.
Okay. So question 6. So what are the 3 classic signs of DVT and why did it require urgent evaluation?
Pain and swelling, and redness at the one side of leg in one leg.
Excellent. Excellent. And why do they require urgent evaluation?
Because, as we said, maybe this blood clot maybe dislodge from the site and travel to the lungs, causing pulmonary embolism, which is a life-threatening condition.
Excellent. Yeah. Excellent. It's good. Muhammad and Ibras, are we all following? Guys, are we together?
Yes, we are for you.
Okay. So question 7 states, list the primary signs of ICP and explain their significance.
Answer, or someone, if anyone wants to answer, or should I? Headache, vomiting, and decreased level of consciousness.
All together on it. Like Dima's head, you have headache,
Vomiting,
right? Vomiting,
and decreased level of consciousness.
yes. Decreased level of consciousness. Good. So
And
what is
patient,
the priority nursing action when a client is having?
the
Sorry?
patient, maybe looks restlessness and disoriented, which an indication of neurological emergency, maybe developed to seizure.
Okay. And we should not forget about the cushion trials as well, right? If it's not caught immediately, and if immediate assessment is not done and intervention, immediate intervention to follow up, you start experiencing late times like the cushion trials, which would lead to like neurologic deficit, or you have death of neurons or part of the brain, which is permanent damage to the brain, right?
Yes.
So question 8 states, what is the priority nursing action when a client is having a tonic-clonic seizure, and what actions should be avoided?
Patient safety. Prevent further injury and protecting the airway.
Okay. What actions should be avoided?
I'm sorry?
What actions, the second part of the question, it states what actions should be avoided.
We must avoid restraining the patient during movement, or insert anything into the mouth.
Good. So avoid restraining the patient or inserting anything into the patient's mouth. Correct. So question 9, sorry, state, describe the initial nursing interventions for a client with spinal cord injury, which is experiencing autonomic dysreflexia. Initial nursing intervention.
Elevate the head of bed, as we previously said, and remove
with the autonomic dysreflexia, it affects the T from from the T6, the span from the T6 and above, right?
Mm-hmm.
Yes. So like like Dima said, you elevate the head of the bed, right, to improve respiration, and then you remove any yes, remove any tight clothing. So the last question 10. So what is cushion stride, and what does it present? What does its presence indicate in a neurological assessment?
Cushing trade,
Cushion stride.
bradycardia and hypertension,
Irregular respiration.
respirations, which is a
So
late sign of
cushion stride, you
increased.
have bradycardia. Yes, that's absolutely correct. So with this, you have bradycardia, hypertension, and irregular respiration. And like you rightly said, it's an indication of late signs of increased intracranial pressure. Okay.
Mm-hmm.
So This you have on the platform or the classroom, you have questions pertaining to what we just discussed today. Test questions like you guys can take, and we'll discuss on our next class. Discuss the ones with the ones that pose a difficulty to most of us. See, you have practice questions. You have the practice questions here.
Yes.
Okay.
Okay.
Oh, good.
So, do we have some other questions?
Oh, good for me. I have to get ready to go to work. Sorry. Thank you.
You're working night shift today.
Yep. They keep changing me every day. We keep changing. All right. Thank you very much.
Every day they keep changing your schedule.
Yep. We'll schedule.
Okay.
Oh, good.
Sure. Guys, yeah. So see you guys same time next week, okay?
Okay, thank you.
Thank you. Thank you, guys. Thank you, Dima.
Yeah. Yes, you guys should always try to go through. Okay.